Good morning, everybody, dear colleagues and friends. I have to say that I'm really happy to be here, invited to talk about one of my favorite topics on reproductive surgery, which is the topic of myomectomy, especially for women wishing to conceive. I have nothing to declare. This is going to be the outline that we're going to follow. We're going to talk a little bit on the impact of uterine fibroids on fertility. We're going to talk about tips and tricks for myomectomy, both for laparoscopy, laparotomy, and hysteroscopy. And we're finally going to have some take-home messages to wrap it up. So starting with the impact of uterine fibroids on fertility, we all know about fibroids, of course. We know that they are benign monoclonic tumors of the myometrium. They are quite prevalent. Up to 70% of women may at some time during their life have a fibroid, especially women of African descent. The data on Hispanic population is limited, unfortunately, and although a percentage of them can be asymptomatic, they can, of course, cause abnormal uterine bleeding, they can cause pain, and they can cause infertility. So we all know about the figure classification, of course, that Professor Malcolm Munro put together. This is the one that we're going to talk about during this lecture. The mechanisms that might lead uterine fibroids to cause infertility are summarized here. There are 6 mechanisms. The first one is pretty self-explanatory, the uterine cavity distortion that especially submucous fibroids can cause. The endometrial and myometrial impaired blood supply that these fibroids can cause, especially when they are submucous. They can also increase uterine contractility, and this might diminish embryo implantation. They can also cause hormonal, paracrine, and molecular changes that might lead to diminished expression of very important genes for implantation, such as this one, the OXA10. And they can also cause impaired endometrial receptivity and gene expression. The closer a fibroid is to the uterine cavity, the more it can cause this effect because of the secretion of molecules such as transforming growth factor beta 3. And this is all gonna lead to diminished embryo implantation. Also, the concept of the capsule. The closer a fibroid is to the uterine cavity, the thicker the capsule can be. And pseudocapsules not only have vessels, but they also have nerve terminals, which might contribute to a dysregulation of the appropriate contractility that the myometrium has to have, especially during the junctional zone. And this will cause diminished implantation. Regarding clinical evidence, we know about studies by Dr. Elizabeth Reed. There are, classic studies, and back in 2009, she put together this nice review and meta-analysis, which proved that especially submucous fibroids leads to diminished clinical pregnancy rate, diminished implantation rate, diminished ongoing pregnancy and live birth rate, and it leads to increased spontaneous abortion rate. Now, regarding intramural fibroids, the meta-analysis showed that when all studies were considered, there was also a big impact there, but when they considered only prospective studies, they couldn't demonstrate that. And of course, we all know that cirrhosis fibroids don't really cause any adverse fertility effects. After this, a number of meta-analyses were conducted, and last year, another meta-analysis by Dr. Elizabeth Briggs came out, and in this meta-analysis, she analyzed intramural fibroids, and she showed that even fibroids that are small, like 2 centimeters, cause diminished pregnancy rate and diminished live birth rate. However, the concept of whether resecting the fibroid, meaning performing myomectomy or not, whether it results into better fertility outcomes is still a source of debate. However, though, we do need to treat these patients in a percentage of cases, and these are the tools that we mostly have at our disposal. We might treat them by laparoscopy, by laparotomy, and by hysteroscopy, depending on the type of fibroid that we have. So I put together some tips and tricks for each one of these surgical routes. So let's start with laparoscopy. My first tip is that we have to ensure the best possible surgical planning. I always tell everybody that surgery really begins in your office. You have to talk to your patients, you have to listen to their story, you have to do a good examination. In my opinion, most reproductive surgeons, we do have to have a good foundation on the topic of pelvic ultrasound. I do prefer performing my own ultrasounds. That way I really know and I can really have a good mapping of fibroids so that when I go into the operating room, I know exactly what they are. And we have to talk to each one of these patients and explain everything and have consent and just draw all the different options so that we can make a shared decision. So this is the kind of workup that we do. We do transvaginal sonography for most of our cases. It's really important to always measure fibroids in the three orthogonal directions and perform a good mapping so that when we go into the operating room, we know exactly where we are. Another tool that we have is hysterosonography. This is a really easy and really available tool. It's very simple to in the office, just put some saline into the urine cavity, and that way we have a very clear picture of how these fibroids are, so that when we go into the operating room, we have a better outcome. However, when we have too many fibroids, or when some of these fibroids are too big, of course MRI is a good tool also. So let's individualize each one of the cases. Another tip, build your A team. These procedures, especially when they're performed via laparoscopy, they are challenging, they might be long, they take a lot of effort, so you do have to be accompanied by a skilled, motivated, and a committed team, such as my team. Now, another tip, let's keep principles of surgical ergonomics in mind. We talked about this during one of the workshops here at the conference. So keeping ergonomics, especially for laparoscopic myomectomy, is really important. These surgeries can be long, they can be tiring, so it's important to always keep this in mind. Another tip, let's learn laparoscopic suturing and practice it until it becomes second nature to you. In that regard, I did have a great teacher, Professor Armando Romeo, who took me under his wing, and he really did give me all the tools that I needed to develop these skills. So suture until you are a master of suturing. Another tip, let's minimize intraoperative bleeding. And we can do this in a number of ways. We usually do this by using diluted vasopressin, but I know that this is not allowed in every country, but at least in my country, in Colombia, this is what we do. And it's important to do this because you're going to need some time to suture, and if it's bleeding too much, then it's not going to be very efficient. So always make sure that you take this type of measures. If you're not allowed to use vasopressin, one other thing that you can do is that you can perform temporary ligation of the urinary artery, such as the technique that Professor Mari taught me in Barcelona. Another tip, perform myometric incisions in a way that's going to facilitate suturing. So this depends on the type of trocar placement that you use. I perform suprapubic technique. So whenever I have a fibroid that is anterior, I perform an incision in a transverse way so that I can suture with my left hand. And whenever I have a fibroid that is posterior, I do it in a longitudinal way, so I do it with my right hand, which is easier because of the axis that the suprapubic port gives me. This case, fortunately, became, turned out to be a spontaneous pregnancy, and this nice baby was born, and this is a picture of the C-section showing this nice scar after the baby was born. Another tip, avoid entering the endometrial cavity. This is very important. And in my opinion, we don't really need a robot to do this. We need really good, laparoscopic technique and adhere to the fibroid as much as we can so that we don't enter the cavity and we have better outcomes such as this one. Always perform contained in-back morcellation. This is important, not so much because of the risk of malignancy, which in this type of population is really rare, but because of the risk of disseminated leiomyomatosis. So we always do this in back, and sometimes when we have many fibroids, what we do is that we perform this type of chain of fibroids so that it's easier to put the fibroids in a bag and do contained morcellation with the technique that Professor Jaime Ferrer taught us, which is really affordable, especially for countries such as mine. Offer the benefits of laparoscopy, even in large fibroids, up to a point, of course, but we can perform this in this type of 8 cm fibroids, such as this one. Again, avoid entering the myometrial cavity. Respect the pseudocapsule, because that way you're going to have less bleeding, you're going to have better myometrial scarring, and you're going to have better outcomes. This is the follow-up just 15 days after the surgery. We can even do it in large fibroids cases, such as this one, putting the same surgical principles in practice. Combine surgical approaches when needed. So sometimes we have cases like these ones where we have both a submucous and intramural fibroid. So we can go in first with our hysteroscope and perform whatever we need, and then go in with the laparoscope and finish the case. This is the follow-up 15 days after the surgery. Now, continuing with the topic of laparotomy. We do consider laparotomy when we are facing multiple fibroids because we believe that laparoscopy is not an end, it's a means. So we always have to think about what's best for the patient. Sometimes we have cases such as this one where we have many fibroids and it's not the size that makes us decide whether we do laparotomy or laparoscopy. It's mostly the location. Sometimes even like smaller fibroids that are closer to the endometrial cavity but they're intramural, we do want to take them out so that the patient has the best outcome possible. And so this type of procedure sometimes we do via laparotomy, and this is the result. And unfortunately, this case also turned into a nice pregnancy after egg donation. Consider laparotomy in cases of very large fibroids. So cases like this patient actually had been operated before. She had a family still. She came from a different city. In that city, they performed a laparotomy, but they couldn't take out the fibroids, so she came to us like 1 year after that, and we performed myomectomy via laparotomy. There are other cases like these ones. Sometimes fibroids can even be so big that they can compress the uterus, and that can cause hydronephrosis, such as in this case. And after taking out the fibroid, when we look at patients 15 days after that, there's no longer any hydronephrosis. Now let's minimize bleeding by applying a tourniquet at the lower uterine segment. This is a resource that we have at our disposal. So we basically perform a window on the broad ligament so that we can use let's say like a Foley catheter and compress the uterine arteries, and that way we can complete the myomectomy with less bleeding. Finally, some tips and tricks for hysteroscopy. So if cervical dilation is required, apply 2 tenacula at 3 and 9 o'clock to prevent cervical lacerations. So what we do is that we put one here and one here. That way we have a lower risk of doing lacerations during dilation. Always respect the pseudocapsule. This is maybe one of the most important topics or tips for myomectomy, any type of myomectomy really. This is not so much of an issue with FIGO 0 fibroids, but when you start going into FIGO 1 fibroids, of course it becomes more important to respect the pseudocapsule. That's the layer here where we have a transition from the fibroid into this type of pinky kind of tissue that's a pseudocapsule, and it's especially important when we talk about figo 2 fibroids such as this one, and also when we start operating on Figo 3 fibroids, which sometimes when they are of a certain size or if there is a previous history of infertility, we are starting to do this type of surgeries on Figo 3 fibroids also. When feasible, use a mini resectoscope to avoid cervical dilation. A lot of these cases are cases of patients that we are performing the myomectomy, and 1 month after the myomectomy, we're going straight into IVF. So we do avoid dilating the cervix as much as possible, and it's feasible to do this type of procedures with a mini resectoscope in many cases. So we do prefer doing that. Always keep fluid balance in mind, of course, to prevent complications of hysteroscopy, which we are all aware of. So this takes me to the take-home messages. Uterine fibroids are common in women undergoing fertility evaluation. Submucosal fibroids and intramural fibroids of a certain size are associated with infertility. What's the size? It depends on the study that we're talking about. The role of myomectomy for intramural fibroid remains debated. Myomectomy is still the treatment of choice in infertility associated with fibroids, and proper surgical training is key to optimize outcomes across surgical approaches so that we can offer our patients the best possible fertility outcomes. With that, I thank you very much for your attention.
Thank you. Thank you, Santiago.